we use the term bottoming out, and we sometimes use it a bit fast and loose. So I think it's used fast and loose because patients and sometimes doctors refer to it as any elongation of the lower pole of the lower pole of the breast being any bit of it below the nipple. So if that elongates in any way, it's bottoming out. But really what I think of as bottoming out is skin stretch of the lower pole of the breast, which is usually a kind of gradual process that happens over months and many years, really. What's the other way that bottoming out can occur? Well, you can see a sort of pseudo bottoming out if the implant falls, the implant footprint falls down the chest wall. And in those situations, there isn't elongation, there isn't stretch of the skin below the nipple. In fact, the implant, by moving below the breast fold, recruits skin of the abdominal wall into the breast. And you can tell the difference because in the first type, where the skin stretches, the scar stays more or less where you left it. The scar stays in the fold. Whereas when the implant moves below the scar and recruits abdominal wall skin, the scar will appear to move up onto the underside of the breast gradually as that's happening. I have to say this kind of thing can happen commonly, and it's one of the reasons that I always fix the inframammary fold. Whether I adjust it or not, I fix it, I lock it in place with some stitches that go down onto rib cage. And that does create a bit of an indented pucker sometimes around the scar, which I don't actually like. But that indented pucker only lasts a few weeks, which is why I think it's a reasonable trade-off. Once the implant has moved and opened up that plane of tissue below the fold, then that plane of tissue needs to be closed back down again. And that's done with stitches, so that's operative. And I don't know of any non-operative way of doing that, I'm afraid. Hope that helps. Bye now.